So I was a house supervisor prior to the transfer center, and I can tell you that we had patients, so I'll just paint a picture for those of you that don't know what that looks like, and probably many of you still function this way, is that you have a house supervisor who carries around a clipboard, and she goes from unit to unit and she tries to understand what beds are available, what level of care, and how many patients she can accept on a shift. And then you have physicians who are actually getting the phone calls, and they are just accepting patients, and they have no idea of what they have for beds, the level of care. Their job is to just listen to the clinical. So we would have patients being accepted by physicians, and they're supposed to call the house supervisor and say, I have this patient that needs to come. And then the house supervisor will tell them whether or not the patient can come. And then the referring facility is waiting for a call back for acceptance. That is a delay in patient care. So now, and we had patients that would show up that we had no beds for. We had no physician to care for them because the physician that received the call isn't actually the physician that's in the hospital. So, and as you know, that's a legal violation. So a transfer center has allowed us to connect the physicians, record the information, and at the same time, the transfer center is located in patient placement, so they can see at any time, in real time, what they have for beds, what's the availability. They connect the referring physician to an accepting physician, not just any physician the operator can get on the call. We actually have a list of our accepting physicians, and then we have a list of our specialty physicians. So sometimes we can get both of them on the call to get the patient accepted. So we no longer have patients arriving without the ability to care for them. My medical director calls it herding cats. How do you herd cats?